Considering that we are in close proximity with each other, we are going to keep on our masks for the engagement that we are about to have. This session is titled Cancer and Palliative Care in COVID-19 and Other Challenging Situations in Uganda, Experiences, Observations, Lessons and Recommendations for Future Emergencies. We have very little time to speak about these three important topics, so cancer, palliative care and COVID-19. And our focus is on the three of them, considering the global pandemic that we face right now. Let's dive right in, and I'm going to start with you, Lieutenant Colonel Dr. Chobe. Considering the many hats that you wear, the pandemic struck the African continent perhaps a little later than others, and one might say that we should have benefited, or we have benefited from learning from the experiences of those that suffered this before us. In this context, where are we as a country?
Thank you so much, Josephine, for this question. It is true that the pandemic on the African continent came a little late, but was not too late. The time span was actually months, a few months. But understandably, it was just a question of time. We knew it would get here, and we did as much as we could. And a major aspect being that we had previous experiences in Ebola where it was a big success. But of course, I want to draw comparisons. Ebola is Ebola, and then COVID is COVID, COVID being an airborne disease. So when it came, and of course trying to look at how the pandemic has been, we, as a country, we tried as much as possible to slow down the transmission, the waves, as we did, and we were actually successful, so to say, and to an extent built infrastructure or improved our infrastructure to be able to respond to this. But as we'll learn later, that COVID is hugely unpredictable, and there was no amount of preparedness before could actually make us be as prepared, because all the preparedness models pointed in different directions. To the extent no one knew that in a COVID everything will narrow down to nothing but oxygen. To the extent that you have a hospital, Mulago Hospital, 900 beds, and having patients on oxygen all the time. So that's where we were, but we had a prolonged wave, initial wave, which ended somewhere in Jan, and then we had a significant, a drastic drop and maximum containment through March and parts of April, till when we had a subsequent wave driven by a variant that came from across the border. So to speak on where we are in a much stable position than where we were 2-3 months ago. Notably, though, that it is not at the containment threshold that we had in March. That's why you're still seeing us having several hotspots, transmissions in different areas. We are seeing in Teso, parts of northern Uganda, West Nile, southwestern Uganda. So to say where we are at that flat level of transmission, but at much higher threshold than what we had earlier. And that creates problems for us that any spike can actually come fast.
I think that for a lot of people, when we have questions coming up about a third wave that's somewhere, is that coming to us? Also because when we start to see the economy start to be opened up, even in little ways, there are questions of laxity that start to come up. So when we also ask about where we are, is it time now to breathe a little, so to speak, or are we still on high alert? Or is this going to be high alert for the next couple of years to come?
I take it that breathing a little doesn't mean to remove masks. So I wouldn't say as I said, we have stable transmission, and that's why we still have free beds. You're not hearing people crying about beds. But certainly, if we don't maintain the observance of SOPs, then we may shorten this period of time and have another spike. And why am I saying this? That the variant that drove the past wave is still here, and actually the predominant wave. And what we do have now is that we are having more people that are infected and with deeper virus penetration across the country than we were then, much as we are having vaccination taking place, which is a little bit slower. But of course, in the next few weeks or months, we're going to be picking up very fast on vaccination. So talking about the third wave, yes, it may come, but we have a chance to really avert it by one, taking up vaccination, two, by observing the SOPs.
Are we more ready for the third wave than we were for the second?
Yes, we were. One is that we have more experience managing. We have been at this for some time. We are mobilizing, and I think in the next few weeks we'll have sufficient or additional oxygen than we were then. Then we are looking at expansion of treatment in hard-to-reach areas. For example, the islands where we didn't then increasing our bed space in additional around 10 to 15 facilities across the country, in addition to what we had. And of course, improving our emergency services for patient transfer.
You spoke earlier, and this is one more question for you before I move to the other panelists. You spoke earlier about the SOPs, and what we realized, one of the consequences, which is pertinent to this conference, was the disruption of efforts to diagnose and treat cancer when we saw the COVID-19 SOPs that were put in place, the measures that had to be extended, the lockdown and so on. And listening to some of the ladies that were speaking earlier, we saw how that affected them. When restrictions are imposed on public movement, patients cannot go for life-saving medical help. What provisions were made, or what provisions are being made even as we speak, to ensure that while we battle a pandemic, we do not lose ground on the front against cancer and other illnesses? But we'll focus on cancer at the moment.
Thank you so much again. We learned lessons from the first wave, where we had a complete lockdown, no transport, nothing. Certainly there was an effect on continuity of services, which lesson we learned that in the subsequent lockdown, the design was in such a way that we would allow movement of people using any means of transport available for them. And it is, initially there was some bit of confusion on what needs to be done. But as in the subsequent weeks, in the second lockdown, that actually was eased, as colleagues here who were in care will tell you. And that came as a lesson from the initial lockdown, where we had complete lockdown, and the access to the clearances at the different levels at the districts was a little bit, very cumbersome, which wasn't the case in the second lockdown. So I entirely agree there was, in the initial lockdown, disruption of that, but the second lockdown we were able to really see that, and the effect was actually hugely minimal.
Right. Well, let's talk about the state of cancer diagnosis and medical care in Uganda, and I'll turn now to Dr. Omoding and Dr. Olusansa. What are the main types of cancer afflicting our population? Perhaps if you could break them down by age group or by gender or any other category that would help us just understand very clearly what we're speaking about and the state of it. Dr. Omoding and Dr. Olusansa. They like to say ladies first, but
Absolutely.
we'll give you the platform.
Thank you so much. Thank you, Josephine. It's a pleasure and honor to be here to talk about cancer, especially in the era of COVID. And to answer the question, what are currently the commonest cancers that we deal with at the Uganda Cancer Institute and Uganda overall. I'll need to mention that our top, 5 commonest cancers that we currently deal with, number 1 is cancer of the uterine cervix, and it's a topmost cancer and the first number 1 cancer among women in Uganda at the moment. And we definitely know that this cancer is associated with a viral infection, human papillomavirus. Second on the list is cancer of the breast, again, a cancer that affects women more than men. For every 1 man who gets breast cancer, you'll have 24 women getting breast cancer. Third to it is cancer of the prostate, and that is the number 1 cancer among men. And it is our 3rd most commonest cancer that we are actually seeing at the Cancer Institute. We've got number 4, which is the Kaposi sarcoma cancer. Kaposi sarcoma is very much very prevalent because of the HIV/AIDS pandemic. And you go down the list to lymphomas as well. But what I need to mention to the audience is of all our top 10 most common cancers, we over 6 or 7 of them are actually infection related. So a majority of our cancers in our region are infection related. In terms of our current incidence, we are seeing close to 32 to 40,000 new cases per year at the Uganda Cancer Institute. And quite more disturbing is that over 20,000 of them die within the year. And a reason to that is a majority, over 80 to 90%, come with very late stage disease. Late stage, what do I mean? I'm talking about patients who come with stage 3 or stage 4 disease, a disease that has spread beyond the origin of the tumor. And most often that is associated with very bad outcomes. In the current era of COVID, we've definitely had great challenges in terms of caring for cancer patients. Looking at a category of individuals who are at a high risk of COVID, and more so just not high risk of infection, but also severe form of COVID infection, are actually cancer patients. During the lockdowns, we have definitely had challenges both in accessing care. Patients could not travel from up country to come to the institute for treatment. We had also challenges in terms of screening. People could no longer access screening clinics during the lockdowns. And in a way, this could have possibly led also to late diagnosis and eventually delay in treatment and subsequently bad outcomes. Other than that, we have also had, of course, challenges in terms of being able to, provide, chemotherapy in a setting where you have both comorbidities, a patient who is having COVID and having cancer. That alone will determine that you must delay treatment initiation until you address the COVID, illness, because it takes a more precedence to care for patients who have COVID and for cancer if both are presenting at the same time.
You mentioned the challenge for patients to make their way to the hospitals during the lockdowns, and I guess Dr. Chove, this points to how we need to do better, even though we did better the second time around from the first time. Dr. Lusansa, yes?
In addition, I just wanted to add to what Abraham has shared with us, that also children get cancer in this country. And unlike the Western world, where cancers in children are mainly leukemia, we have lymphomas. And as he mentioned, most of our cancers in children here are also associated with infections. And in addition to that, we also get solid tumors like nephroblastoma, which is a cancer of the kidney, and other solid tumors. But it is important to know that a cancer such as Burkitt's lymphoma was first described in this country, and it was very prevalent in this country. It's still prevalent, and it's associated with malaria and other viral infections. So also children get cancer as a special group.
Yes. I was actually going to ask you, when Dr. Muding speaks about infections, and you've mentioned them as well, what infections are we speaking about?
So the infections, most of the infections that are associated with cancer causation are viral infections. viruses have the capacity to input their, once they have infected the human being, they have the capacity to adjust and put their viral genome. Activities that promote cancer development. I think that's how simple I can make it. And many of these viruses are prevalent here. Viruses like the Epstein-Barr virus that is associated with lymphomas and Burkitt's lymphoma. Viruses like the human papilloma virus that is associated with cancer of the cervix and some cancers of the esophagus. And viruses like hepatitis B that works in a different way that is also prevalent in this country. So by and large, the viruses are small particles that are able to adjoin their DNA to the DNA of the human being and switch on cancer causation. So that's how we get it. And most of these viral infections are also related to poverty and overcrowding, as you know, hepatitis B, EBV, and all the other viruses that are associated with cancer. And HIV, the big one in the room, which just plays around with the immune system, and the immune system is plays a big role in prevention of cancer, because by and every day there are cells that are becoming errant, but the immune system has a housekeeping role that it does to remove all the cells that have become errant, that are on their way to become cancers. So HIV affects the immune system, and that activity, which would override all the other things that are going on, is lost. So that's why patients with HIV, in addition to having the other viruses, have that. And the other one that I haven't talked about is the human KS virus, the human KS virus that is very prevalent in this country, that some studies have estimated it at about 60%, and it's spread through saliva, and somehow that predisposes even people who don't have HIV to getting Kaposi sarcoma. So many of our infections here, if you look at the top 5, many of them are associated with viral infections that are prevalent and are silent in us, but when something goes wrong, the immune system is unable to clear the errant cells, and that's how cancer grows and develops in our people.
Thank you very much, Dr. Lusasa. You want to add to that?
Yeah, I think other than the viruses, there are also some bacterial infections that are actually known to predispose or increase, heighten your risk for developing cancer, and particularly for stomach cancer. There is commonly people go around testing for it. It's called Helicobacter pylori. Colonization of your stomach over time may actually lead you to development of stomach cancer as well. Other than that, why yet COVID is a new virus, and I think being an oncologist, and I think it's something that we're going to look very intently to see if it alone might actually lead to cancer causation down the road. But as we have discussed, I think over 60% of all our cancers are infection related. Okay. And that definitely offers a very good paradigm for cancer control. If we control the infections either through vaccinations or through timely treatment, we could actually be able to avert or reduce the incidence and ultimately the prevalence of cancers in our region.
Okay. The medical expertise and the facilities that are needed to deal with cancer seem to only be available, and I'm speaking from a point of ignorance here, so it would be nice to get educated. They seem to only be available within the big cities. So we'll have them in Kampala, we'll have perhaps in Bulu, we'll have in the big cities. Is it likely that there are many more undiagnosed cases in the rural areas? And what is being done to expand the medical services to other parts of the country? Again, this is to Dr. Muding and Dr. Lusasa. Dr. Lusasa, you'd like to start? Okay, you'd have to be a bit louder because the mask, Okay.
So the Uganda Cancer Institute has the mandate to oversee cancer care, cancer research, and cancer training. So it is true that many of the patients who are from rural areas, if they don't have transport, may not be able to access care. But there are plans that are underway, that are ongoing, to ensure that there is decentralization of cancer care, by region, and making sure that there is a timely diagnosis and timely treatment. Yes, there's been overcrowding at the Cancer Institute because it was in the past, it was the only center that was treating cancer in the country. And as we are aware, cancer care is a specialized service requiring a lot of training, requiring a lot of expertise. But I must say that we have a center that is really active in Mbarara that sees over 1,000 patients per year. And through the pandemic, this was very active. We also have set up in Arua Regional Referral Hospital, we have a center that is starting with at least diagnosis, and we are hoping that as we are capacitated via human resource, we shall be able to start also services similar to the ones that are in Mbarara. And as I speak, the Gulu Cancer Regional Referral Center is under construction, but also there are plans underway to make sure that we start the service even before the building is there. And also there are plans in the eastern side to also have the Mbale Cancer Center. So we, as the UCI, are planning to take the services back to the community and make sure that there is easy accessibility. But all this requires money, all this requires training, all this required facilities, as the infrastructure is not there, and there is need for a lot of development. For example, setting up radiotherapy centers in these centers. Just a bunker and a radiotherapy machine and the radiotherapy team as well as the oncologist there. But as we speak, those are plans that are underway and they are taking place. And in as far as we also have a community cancer center in Mayuge, because the Busoga region has a lot of cancer. So we have a community cancer center there, which mainly is doing a lot of screening. And in addition to just screening, there is referral to Jinja Regional Referral Hospital. We are collaborating with the Jinja Referral Hospital in the management of cancer of the cervix, because we have camps there and we have a service there. And then that is coordinated straight to the Cancer Institute where the need is required. And on top of that, even the Cancer Institute runs mobile screening services. Before the advent of COVID, we used to actively go to communities on a timetable, on a rota, and go and screen and be able to send back patients for care. But as we are all aware, such services and such activities have been hampered by COVID, but we hope that when we are assured that it can be done in a safe manner, we can do it. But that said and done, we are also now taking on the role of working with partners at the different centers. We have a new center here in Owino, where we are working with the clinic there to see that screening activities take place. So we are rethinking how we do this, that we need to go back and work with the centers, train them, empower them, and then they can send the patients to us as we continue, given the new norm that we are living in.
What is the state, and Dr. Moding, this is for you, what is the state of cancer treatment in the country as we speak? Are there any cancers that we can now manage better, for example, through preventive screening, lifestyle changes, or even medical interventions?
Yeah, thank you, Josephine. To add on what my senior colleague, Dr. Victoria, has stated before I answer that question, you know, currently we grapple with very late stage presentation, and as you hinted earlier on, it's definitely a factor of a challenge of accessibility to care, and we currently are possibly seeing close to 4 or 5% of all the cancers that are in the country. Yeah? You could possibly assume the other 90 plus are actually undiagnosed. Eh? And partly that is because for a long time, cancer was purely, Cancer Institute was purely based in Kampala, and everybody who had to come for a cancer diagnosis has to journey to Kampala to have a diagnosis done. As Dr. Victoria has hinted out, I think the Institute has begun to roll out to all the regions. And of course, the intent of that is to take care close to the community so that it becomes more accessible. And ultimately, with that initiative, we are looking forward downstaging late presentation. And then once you downstage late presentation, then you're actually able to enhance or increase your cure rates as well. That brings me to answering the question. Yes,
the funds,
absolutely.
A lot of money.
It's a colossal sum of money and commitment from government, which government has already, given us, initiatives and some funding to do that. Of course, it's not yet enough, but it's good baby steps that we have actually taken to actually improve and roll out cancer care. The question you asked about, are there any cancers that are curable? Are there any cancers that we can treat now locally? Yes. Speaking from, the last couple of years, we've been working at the Cancer Institute, we've actually seen a number of cancers that are actually curable. And of course, cure is hinged or dependent on stage of presentation. If you presented with early stage disease, you're definitely likely to cure that cancer. If you presented with late stage disease, you're unlikely to cure that cancer. So the stage at which you present is very critical in determining your curability. Secondly, the type of cancer that you present with. World over, there are cancers that are known to be curable, and there are those that are not curable. For example, if you presented with, let's say, looking at stage, for example, breast cancer, for example, our number 2 cancer among women, if a lady presented with early stage breast cancer, the chances of curability are over 80%. Stage 1 or stage 2 breast cancer is curable, and we are able to treat that now here in Uganda. Similarly, if you presented with a cancer, for example, that affects the lymphoid system, what we call lymphomas, 90% of the time those tumors are curable. And amazingly, even in the advanced stage, stage 3, stage 4 lymphomas, you can approximate 60 to 70% of the time to cure it. And those we are able to treat here in Uganda. Bowel cancer is the other cancer that can be curable if you presented early, and definitely it's also on the increase because of our changing lifestyles. We now eat diet that is far different from the diet that we ate 20 or 30 years ago. What my mother ate 20 or 30 years ago is different what I could have had for lunch today. And that alone is one big risk factor for why we are seeing an increase in bowel cancer. But however, if you presented early, and how do you present early? You definitely must adhere to the screening guidelines that we have. You must at least have, a fecal occult blood test in your stool maybe once a year. If you've had a very strong positive family history, please do go for a colonoscopy to look through your bowel. So in summary, Josephine, we do have curable cancers, but it's hinged on the stage at which you present.
I think the hope that you're giving, Dr. Moding, is when you keep saying it can be treated here in Uganda. Because the thing about cancer now is every time you see a poster about someone with cancer, they're looking for money to go to India, they're looking for money to go somewhere, and that's quite a strain. So to hear that some of these you can treat here, that's a lot of hope.
Absolutely. I think gone is the time when many of our patients actually thought going out was the only hope. We've built infrastructure in country. We've trained people in country, both out and in country as well. And I think we've, Dr. Victoria will add on, we do have a team that is actually able to handle cancer in country in Uganda. And definitely outside referral is only subject to if we are not able to really handle those cancers in country. So I think that is something we should be proud of as a country and as a people, that we are able to contain this. During the lockdown time, a majority of Ugandans were not able to travel. And I think all of them were cared by the Uganda Cancer Institute.
Yes, Doctor.
You wanted to know the status of cancer care and treatment in the country. Cancer treatment is multimodality. It's not one form of treatment does not treat cancer. We need a big team, and that team is being assembled. In addition to that team, you need equipment and you need all the inputs. So in as far as chemotherapy is concerned, which is the medical oncologist's duty, we have a lot of drugs. We are privileged to now have drugs that we didn't have 10 years ago. We, even during the lockdown, had at least 80% of our molecules present. And the only catch was that because of the lockdowns, some of our suppliers could not bring drugs in. But once the lockdown was released, most of the drugs came in. So we have drugs, and in this region we have the best drugs. We have drugs that are coming from very reputable pharmacies like Novartis, like Roche, And we are dealing at a very good level where they are giving us drugs at a very, very competitive price. So we have drugs at the institute. We have radiotherapy services. We have 3 equipment. We have a LINAC. The LINAC that we have today at Cancer Institute is the best in the region. We even find it funny that a patient will travel to Nairobi to have radiotherapy with a machine that is inferior to ours. We have trained staff. We have one of the best staff coming back from South Africa. They wanted to be retained there, but they had to come back because they had gone there for 4 years. So as far as radiotherapy services are concerned, we are building. We are building.
I think then my question is where are the gaps in communicating this information, that we have the resources, that we are able to actually treat people, because it looks like the first option is, leave the country, go somewhere where, you'll get a machine that's working, go somewhere where, you'll get drugs. I was interviewing somebody over the weekend, and they told me they were getting their drugs from the Uganda Cancer Institute. The drugs are expensive. I think he was saying 2-point-something million per, And he said it was at the Cancer Institute, and I said it's there. He said, yeah, it's there. There just sometimes when it's not there and I have to buy it from elsewhere, but sometimes it's there. Where are the gaps in communicating this to the public?
I think we as Cancer Institute will have to improve in our public advertisement of what we do. But it's good that you also heard it from the patient themselves, not from us, that the drugs are there. Because government is even buying molecules as expensive as 2.5, as 3.5. And every time we talk to the budgeting committee, we let them know that we need more. Even other drugs that are as expensive and we are not here or are not even in the region are there for prostate cancer, for lymphomas. Our lymphoma, for example, our lymphomas, which we actually insisted, because wherever you are, you should be able to treat a lymphoma and a patient gets better if you have all the molecules. So all the molecules are available, including rituximab that used to cost 6 million. We get it at a subsidized fee, and patients get it for free. So I think it is the numbers, and maybe the previous negative image needs to be washed and needs to be rechanged, that people understand that things are not the way they were. Things have gradually improved, and we are in a better place, and we shall continue being in a better place as long as we continue the way we are.
Thank you very much, Dr. Alsansa and Dr. Muding. I'm going to allow you to have a bit of water to drink while I now turn to Dr. Birungi and Ms. Juanuka for the next set of questions. So we started with Dr. Chove to set the stage, and then we went to look at cancer. Most people know about COVID-19 now because of the awareness that's been done. A lot of people know about cancer because there's a lot of noise about cancer. Somebody in your family probably has been through that. But not a lot of people understand what palliative care is. Can you very briefly outline it for us?
Okay, thank you very much, Josephine. I will go first, and probably Dr. Doreen will go next. Palliative care is a service that is given to patients with life-limiting illnesses, life-threatening illnesses. COVID-19 has also called in for palliative care. Palliative care aims at improving the patient's symptoms and making this patient feel comfortable, but also making this patient be independent. And also it looks at the patient as a whole, and also looks at the family as well. So it does not just focus on the patient, but it focuses on the patient and the family. And when I say it looks at a patient as a whole, I mean they address the physical issues. Palliative care addresses physical issues, that is the illness, psychological issues, the mind, social issues, the people around him, what do they think, what do they feel, how do they feel, social issues, so that this patient is made comfortable together with the family members. And when a disease definitely strikes, the entire family gets sick. So everybody needs to be involved in the care. They need to know what is happening. So that is what palliative care is all about.
Okay. Let's talk about availability and affordability. Unless Dr. Birungi, you want to add a bit on what palliative care is?
Maybe just to add that in the past, palliative care seemed to be something that is reserved for the dying, and that is not entirely true. In it has a very positive impact on patients who are, yes, they have a life-limiting illness, but they are not dying at that time. And we have seen at Hospice Africa Uganda, we've seen patients who've lived on for years, even after their life-limiting illness has been diagnosed. So it has a very positive effect on the patient and the family. We've actually seen patients who have come back into gainful employment after suffering, you know, this illness and being sick for a long time. It's also important at the time of dying, I must add, because very many people do not know how to deal with that moment. And with palliative care providers have been, you know, in a very difficult place sometimes, because you're looked at like you're coming to prepare us for death, but then some people actually want that preparation. So it's an interesting kind of specialty, but it's a very impactful service, and many patients that have actually experienced it, they really testify that they have been supported. Yeah.
In the situation that we are in, already a lot of patients struggle with being able to afford medical treatment. And now when you bring in the aspect of palliative care, it feels like it's an option for the moneyed class only, people who have extra money to spare to send their person, you know, to now a specialized place to take care of them, like you said, in their last days. Is that what it is?
I think in some countries abroad, hospice care is very expensive, and it's something that not many access. But here in Uganda, the services, we make an effort to make it as affordable as it can possibly be. Actually, can I say free to the patients? Most of the service providers in the area of palliative care, the hospices and the health facilities, both government and private not-for-profit, they actually are providing this service at almost no cost to the patient. So what tends to happen is, because it's difficult to run a completely free service, we kind of ask patients to make a contribution where they can, and many of them do it really out of appreciation, but it's mostly affordable to the patients. What makes palliative care expensive really is looking at the whole patient together. When you look at devices, things like colostomy bags and other equipment that patients may need, catheters and things like that, for their comfort, for their better quality of life, then it seems very expensive. We've really had very touching testimonies when it comes to affording such things. But in many of the hospices, there's an opportunity to get some of these things at no cost, because they may come in as donations. And the Palliative Care Association of Uganda is really working hard to get the policy in and to get government to have a budget for palliative care medicines and devices in order to make it even better for the patients.
I would probably like also to add that palliative care is one of the essential services that Ministry of Health offers to its people. Therefore, when you get to government health facilities that are accredited to provide this service, because it's not each and every hospital that will provide the service, there has to be a trained palliative care officer to provide that service. It is free of charge. It is a service like any other service, and they try to make sure that these things are available. As you know, some of the things may not be available, then they can get them outside the hospital, but otherwise the services are available in our health facilities as long as they are accredited, and the healthcare workers are there to provide these services. We have about
the rest of the rural parts of the country, and we're not just focusing on again, like I was mentioning earlier, for even cancer treatments, the districts, the cities, but just going down to the grassroots to make sure that this is available
Palliative care services, we haven't reached each and every district. I think palliative care is in over 97 districts of Uganda. About 223 healthcare services or health centers are providing palliative care services. We have about 23 districts that do not have palliative care services as yet. But the Palliative Care Association of Uganda, together with the Ministry of Health and partners, are working hand in hand to ensure that all the districts get palliative care services. Because as you realize, it is a service that is required and it is a service that we need, and you never know when time will hit and you need palliative care services.
Was it affected during the pandemic?
Pardon?
Yes. Was it affected during the pandemic, this service? And,
yes.
and how was it affected? I see you both nodding.
I'll speak specifically for hospice where I work. And the 3 sites, we have a site in Hoima, Little Hospice Hoima, and a site in Barara, Mobile Hospice Barara, and then here in Kampala. So the first lockdown was very difficult. There was totally no transportation allowed, and it was very, very difficult. We told patients follow the procedures the government has put in place, but it was very hard for them. And you know, when you're very sick, and the usual thing is to find you at home, and then we struggled initially to even get the permits to get us to go to their homes. So these kinds of patients, getting them onto available transport to come was very hard. So we did a lot of telephone consultation, but it's very difficult to talk to a patient that you wish you could look at and touch. The second lockdown was a bit better because we managed to get permits in time and were able to continue to do some home visits. But then the outreaches have completely been difficult to implement. We have about 7 outreaches in total that we run across the country, but it's been very hard to implement those outreaches. Again, like Dr. Victoria was saying, we need to figure out a way to do it safely and have enough like PPE to do this kind of work. But patient transport is still a very big challenge. Some of the transport costs are still very high for most of the patients. They come to us and they can't go back, so we have to look for some money to give them to go back. It's really a challenge. Yeah.
For the viewers that are watching us online, if you have any questions for the panelists, please send them on online, and we'll be able to look at some of them. I've seen a couple that have already come in. Dr. Chova, I'm going to come back to you. National response to COVID-19, the challenges, the lessons, and the future perspectives with focus on access to essential health services such as cancer and palliative care. I noticed when Dr. Brinji was speaking, she was looking at you out of the corner of her eye, a bit shyly, but to speak to the fact that access to these services was still hard, even with the second lockdown. What lessons are we learning, and what are we looking to the future to do better?
Yeah, I do appreciate that, again, as I said at the beginning, that this first lockdown, things were really tight for continuity of care, not only for cancer, but also for other illnesses. Luckily, we didn't see a major change in numbers, most especially mortality, but it's not anything to celebrate about. The second day lockdown, certainly, as I said, we looked at all this and thought and knew that we have to have patients move and to be able to refill their treatment, to get to care for diagnosis, and then of course referral. And that's why we had mechanisms where we had that a patient can use any means of transport to get to care. But it's a big lesson that we've learned, that in the subsequent, if there be anything like this, and of course we need to understand that COVID is a new thing, and we had to learn as we move, and we had to adjust as we move. And the thing next is to make sure that colleagues who are working in chronic care settings need to be brought on board when you're planning some of the aggressive interventions. And I think that's a big lesson we've learned, to understand the dynamics that existed. But the problem happens here that most of the things come quite fast, and we have to take quick decisions. And we go back and then work with the colleagues. But that's a big lesson we've learned, and then we will have to have. But the other thing that we see is that we've never had a prolonged outbreak, at least in much of our time. I don't want to compare this with HIV, which has been around for 40 years. But we've never had a prolonged outbreak and coming in waves, sometimes very aggressive waves. And some of these things, as they come, may not be predictable. For example, we knew the second wave would come, but we didn't know when it would come. And that's an area, and of course, understandable. Of course, and the magnitude, and the magnitude, because we had the previous one. And you recall, people used to praise that for us Africans, we are immune to COVID and all that.
Fun.
And that fell wayside in the second wave. So that's one. But of course, we need we've learned that most of the things we do, we need to work and adjust as we move, and make sure that we have scalable interventions in either direction, and also be able to pay particular attention to specific categories. And for example, as you do see in the vaccination, the 500,000 people with comorbidities, certainly we do have a challenge on the actual census of that category. And that 500 was modeled. So there's a lot that we need to know, how to keep data, how to gather information from the different chronic care settings. So, yes.
Oh, all right. Thank you very much, Dr. Chole. Two questions. One is going to go to Dr. Moding and Dr. Lusansa, and then the other question I'll send after. So the first question is there any collaboration? This question is from Benon Fred Twinamasco. Is there any collaboration between Cancer Institute and UNBS to identify the cancer-causing products to mitigate the cancer prevalence in Uganda in the spirit of prevention is better than cure? Yes, Dr. Alsasa.
There is a collaboration, and when we were setting up MAYUGE, that is our Community Cancer Research Center, we actually collaborated with UBOS to identify and map out the kind of people and the population. Because the only other population-based registry that we have is the Kampala Cancer Registry, which only looks at Chadondo. And we realized that many of the cancers are not coming from here. And unlike the other researches that are led by collaborators from out, this cancer registry, this Community Cancer Research Center, is aimed at looking at a community that is living and looking at the incident cancers and going back to find out what is causing them. We have such a center in Mayuge district, and it's covering a population and the districts surrounding it. We are hoping that in the future, having learned some lessons from this, we shall set up such community research centers in the north, in the east, and in the west. But we have one like that, and it is with collaboration with the Uganda Bureau of Statistics, and it played a very big role in delineating and demarcating and looking at the population, because with time we shall be able to publish this data. But yes, there is room, and there needs to be real concerted effort to look at the different emergent cancers that are coming in the country that cannot be explained, or maybe could be explained by the different practices that are prevalent in the different regions. Those are the kind of researches that we plan to undertake or are beginning to undertake.
Thank you very much, Dr. Lusansa. You've spoken about the Uganda Bureau of Statistics, and that's very key information for us to have. Fred's question also speaks to UNBS, so we're looking at standards as well. Do you want to speak to that, Dr. Omoding?
In terms of standards of cancer care, or the question is...
In terms of standards of cancer-causing products that might be on the market.
I'll possibly beg to defer that back to Victoria, but as far as I know, I think, as Victoria's pointed out, our engagement with the Uganda National Bureau of Statistics and is very much on mapping out a population and trying to get us, yes.
The Bureau of Statistics,
yes.
Not with the standards.
No. I think in terms of clinical care, I think it's possibly a very different entity that we engage in.
Causative agents and causative things that we will have identified, then we can go back. But we cannot go to UNBS and tell them this is causing this, this is causing this, if we do not have the data. So it is the data that is going to inform us, and then we can go back to the root cause and say, this is what is causing this, and I think you need to regulate this. Definitely, yes, we know certain things that are happening, like taking cigarettes, but is it to do with quality of cigarettes? Taking cigarettes and taking alcohol, we know that those activities are taking place.
I think they also speak to creams, because usually that's what people speak about the most.
Let us see what the data tells us, that most of the people coming in with the skin cancer in this area that we are studying are taking up creams, and then we can go back. But I think without data that is plausible, it's very hard to go and say, check this, because I think they are doing their duty as per the guidelines that are set aside for different countries as far as the quantities of quinolones and whatever that we think is carcinogenic. But as I speak, I think we are going on the ground to get the figures and study these cancers more close up, and then we can share the data and look at the different agencies. It may not only be UNBS, it may be also other agencies, including the ones controlling pesticides, the ones controlling the salts that we take, and even the different ways in which we prepare our feeds and food.
If we have any question from this side of the audience, please just let me know. But I will pose the next question that's coming to Dr. Birungi and Ms. Chiwanuka. The question is on palliative care, and it's from Barara Regional Referral Hospital. This conference, so this is the question, this conference has demonstrated that the biggest population of our cancer and HIV patients need palliative care because they present in late stage of disease and most have socioeconomic challenges that prevent access to sophisticated care. How can we advocate for substantive support for the people teaching palliative care in our institutions of higher learning, like universities? They need to prioritize recruitment of permanent lecturers of this essential skill as a strategic way to ensure sustainability of palliative care. The challenge we have as trained palliative care providers is that we are not recognized as such. We have to do our usual duties, and palliative care is done as an extra mile. This is the reality, and this stifles provision of care. I can see that Ms. Chiwanuka is vigorously nodding. There must be a story there. Do you want to take this question?
I will take it and she will contribute. Yes, I think the person who has said it, it's a reality, because that is what is happening across the country. But this morning, I think we had our Director Clinical Services give his remarks. The palliative care is getting to get recognized, because now the Ministry of Health has established a palliative care, should I call it a directorate? Because they are hoping to get an assistant commissioner for palliative care, but for sure the palliative care trained personnel throughout the country are currently are doing the work as a by the way, as an added thing. If you have interest, you will do the work. If you don't have the interest, then the patients will suffer because they are not properly put in the structure. So that causes a big challenge, but there is a lot of advocacy going on to make sure that those palliative care officers are recognized, and also the effort to ensure that the policy is signed off. I think that will help a lot. The Ministry of Health is working very hard to ensure that the palliative care officers are recognized, because they have even established positions of consultant palliative care personnel, special grade palliative care medical officer, and other positions. So let us be hopeful that things are going to get better, and with the policy which we think will be signed off this year, I think things will get better.
Okay. Dr. Birunji, you want to add to that?
Yes, it's really about us being hopeful, because once we have that palliative care policy, it becomes much easier to do the advocacy we are talking about. But we also saw a notice that came in from the Ministry of Health requesting the regional referral hospitals to set up palliative care units within the hospitals. So we are expectant that those positions will actually be filled. Okay. In terms of training palliative care, yes, there is a big gap in the country, and we are hoping that the policy will help, because there is an institute of training palliative care at hospice, but also there is another training, the other two training centers in Mulago, the School of Nursing, and in Mildmay. But we need to see this training happening at the medical schools, and there is some partnership happening for Makerere University Medical School, but then we need to know what's happening with the other medical schools in the country. So we are very, very hopeful that the policy will really help us to look into those details and fine-tune the palliative care provision.
Okay, thank you. We have another question that's come through, and this question I think then is for Dr. Moding and Dr. Lusansa. What is the mandate of the Uganda Cancer Institute?
Okay.
The mandate of the Uganda Cancer Institute is the name the institute in many people's mind comes up as a training center. But you know, when the Cancer Institute began, it was purely mandated to provide care for patients who are diagnosed with cancer. But over the years, that mandate has actually evolved to a mandate that befits the institute, and that includes, right now, we do right from cancer education and awareness creation about cancer through our comprehensive cancer control program that travels back and forth around the country, really to talk about cancer and also to do screening off-site. The second mandate is definitely diagnosis as well. We've built infrastructure within the Cancer Institute, both in terms of hematology and pathology and imaging, to be able to diagnose and know the extent of cancer if you're diagnosed with. The other mandate is to do with treatment. You cannot diagnose and not treat, otherwise you wouldn't be relevant. So we actually do provide cancer treatment as well as our mandate. The fourth mandate is training. So the Institute has taken on training as one of its really very strong arms. And in the recent past, we have had both training for nurses and training for doctors. And to that, I'm very proud to talk about the Institute, because we've set up fellowship programs. These fellowship programs are definitely with a singular purpose to train locally clinicians with super specialization in cancer care. Something in the past that myself and Dr. Victoria traveled out for training, but now we're able to train locally. And the Institute has evolved to become the East African Center of Excellence in oncology. And its mandate purely for that is to train skilled labor or manpower for cancer care, right from the pediatric oncology. Those are doctors who treat children with cancers, to adult hematology oncology fellowship programs for physicians who treat adults with cancers, and gynecological cancer fellowship programs. And we're moving on to even provide surgical oncology and radiation oncology training in country. That is the other mandate of the Cancer Institute. Of course, the other one is research. And the Institute is very much involved in lots of research programs, both internally and in collaboration with other institutions, locally and internationally. The other mandate Dr. Victoria will possibly add on is definitely in drafting the National Cancer Control Program for the entire country. And we can speak a lot about the mandate, and of course also now development of cancer centers all over the country. As Dr. Victoria alluded earlier on, it's been the mandate of the Cancer Institute really to roll out cancer services countrywide. Right. Yes.
Dr. Alsansa, perhaps in adding on to what Dr. Moding has said, I've had really great things said about the children's section. I don't know if you want to give us a bit of information about what good things are happening there, what changes have been made, and any improvements still also in the Cancer Institute.
Okay, thank you. For the children, we initially had one ward looking after everyone, but over the years we were able to separate children as not young adults, but children who need specialized care and children facing a life-threatening illness. And we have pediatrics. We have a pediatric unit running both an inpatient and an outpatient service. We have trained and continue to train pediatric oncologists, and we have a service that has, among other things, has a play area, has an outpatient that is kitted to just cater for children. Children have a separate infusion area, so they do not sit with adults. Children have their special clinic. They do not are not attended to with adults, because sometimes some of the things they may see may actually frighten them. We have child counselors, we have child-friendly nurses, and we have people who have just specialized in looking after children. And I'm proud to say that next year, we shall be hosting, as the Cancer Institute, we shall be hosting the SIOP meeting. Our head pediatrics is the incoming and incumbent president of the SIOP, and we also are engaged in cancer research in as far as children are concerned. There's the activities to see that we improve the nutrition of children, and we have collaborated with people who actually provide special meals for children who are sick. At least children are assured that they will get a balanced diet, because we know that most of our children are coming from very poor homes, but at least there is a balance. The children are assured of getting a cup of milk every day. So the way we feed our adult patients is not the way we feed our children. Sometimes with support from our collaborators, they get extra, and even when they are in for the outpatients. And from time to time, before COVID, we used to have days when they would meet and get encouraged by other survivors. It's been quite hard. We have special days where we celebrate children who have finished their chemotherapy and they get to get the badges and make the walk. And definitely we celebrate with them when they have gone through the fire. So yes, the child's cancer service is unique because we are dealing with unique people, special people, and the key to our emphasizing that is that childhood cancers are curable because they are taken care of, and many times they can be treated to cure, and that is what we are aiming to do. And they need a lot of support because you deal with a family. Many times the people making the decisions for the care are actually not the patients themselves, it's their families, and they need support to make the right decisions for our special patients. So I think in a nutshell that's what I can say, but there's a lot of activity and a lot of excitement, and there's a lot of room for growth in the child cancer section, and we have a lot of enthusiastic team members there. We recently also acquired a pediatric surgeon because cancers, as I said, are managed by a team. It is not only medicine. You need the operations on time, somebody prioritizing cancer, not thinking about other things. So at UCI we have a pediatric surgeon. We are also hoping to improve the HR in that area that is just specific to children, not just looking at them as small adults and therefore just reducing their doses. There are many other things that take place in taking care of a child with cancer beyond just treatment. The support, we have many collaborators, for example, who come in even from the different 3C. What I didn't share is that we have 3C clubs that we in the room, and in a bid to increase awareness, we took on cancer clubs, and children, most of the schools around the country have 3C clubs. These are children caring for cancer, and they talk about cancer, but these clubs actually come in and support the children. Okay. One of the things we would like to see, also to see that our children who are on treatment do not get their education interrupted, so there is what we call school health, school therapy, so that we have somebody who can actually walk through the children and tutor them through even during the time that they are here. One of the best P7 candidates actually was a child who was receiving care at UCI, and so we do also that support, because the child should have hope, not think that everything has come to the end because they have a cancer diagnosis.
It's very encouraging to listen to what's happening at the Cancer Institute. It's very far removed from the stories that we see a lot of the time. When you hear about cancer, you think death sentence. You don't see all of the things that are happening at the Institute. Another question here for on palliative care from John Mwai, Rays of Hope Hospice, Ginger. How are the governments, especially in Africa, helping in promoting palliative care, because it has become another part of normal that we need to handle so that we can improve the quality of life of the people? So I guess the question is, where has the government come in to support palliative care?
I would say that especially for Uganda, we've really worked with our government very well, because most of the things, some other countries have not managed to move because they do not have the support of the government. But for us, right from the time palliative care was introduced, the government was there. I remember by that time there was the minister, James Makumbi. He accepted that morphine get imported into the country so that patients can receive that medication in the right form. And if it wasn't for that, then palliative care wouldn't have progressed. But also our government has supported some of its healthcare workers to undertake palliative care training. There is also a program of the PPP, public-private partnership, that is making sure that the medication of choice for pain control, that is morphine, is brought in, and the government has a very big role in that, and that medication is given out free of charge. So all that is support. But also when you hear what is happening, establishing a position at the Ministry of Health at a level of an assistant commissioner, I think that is very, very important. Instructing all regional referral hospitals to establish a palliative care units, and putting positions there of consultants, all those positions. I think that is very important, and that has helped Uganda to move really a notch higher, because if you look at other African countries, that has not happened. And if we didn't have the political will, if we didn't have the government support, I don't think we would be where we are right now.
Thank you very much. I'm going to come back to Dr. Omoding, and I will also come back to Dr. Lusansa on the question of UNBS involvement. And again, Fred is saying it is on a mandate of research by the Institute that I premised my question on how the Cancer Institute collaborates with UNBS to inform the need of which products should be critically checked for standards from patients' demographic information. But even in responding to that, there's another question from Rosemary Kamfua, who says, to Dr. Victoria, thanks for the presentation. Is it possible to engage UNBS earlier based on some common facts such as aflatoxins and preservatives in foodstuffs being carcinogenic, such that the Ministry of Health and UNBS tackle some of the possible cancer causations preventively as research is progressing?
Thank you very much for that question, Fred. Once again, Dr. Victoria will add on. My understanding is the Cancer Institute, as earlier alluded, does research, and that research eventually informs policy. The Cancer Institute is engaged in drafting the National Cancer Control Program, of which actually now rings into my mind that the Uganda National Bureau of Standards is definitely a part and a parcel of that cancer control policy.
Okay.
They definitely must be on board.
All right. Someone has come to save the day and take the question, so let's hear from you, Doctor.
Thank you very much. I have not really come to save the day, but I've just come to add my voice to this discussion because, one, to just make this fact that cancer is a multifactorial disease. There's no single cause. And that's important for, everyone who is following the discussion, whether on Zoom or, here. It's important to know that there's no single bullet that can prevent cancer. And when you look at the products that we receive in this country, in terms of, whether the food is imported, the preservatives, my senior oncologists here may not get evidence to pin one and say this is responsible for majority of our cancers. That's why Dr. Victoria and Dr. Omodin came to emphasizing that 60% of our cancers are associated with infections. But even if somebody has human papillomavirus infection, which is, I think, one of the strongest viral, risk factors for cancer, it's not 100% that they must develop the cancer of the cervix. There are other factors that come into play. And this is important, very, very critical for all of us to appreciate that if you want to reduce your risk for cancer, there are many things you have to do. You have to be vaccinated. You have to practice responsible sexual choices. I pause there so that somebody can think what I mean. The number of sexual partners, the practice. You have to choose the diet you eat. Abraham's talked about, the diet being responsible for many of the cancers increasing. He actually said the food his mother ate 20 years ago is different from what he ate at lunch. So even as we choose what to have on our plate, on our menu at home, we must be responsible, deliberate, and objective.
So just to relate that to this question again, while you're there, before you leave, is it possible to engage Unbs?
Excellent. It's very, very possible and very important and necessary. But why I'm emphasizing this is that our viewers should not think NBS can protect us alone. But it's possible to engage NBS. And I think in the National Cancer Control Plan we are drafting, we are including the role of NBS so that right from the policy level, it's clear what NBS can do to support cancer control.
I think you need to keep saying UNBS. There might be a bit of confusion as to what which organization you're speaking about.
Sorry, UNBS, Uganda National Bureau of Standards.
Yes.
Let me put it in full.
Okay.
So thank you very much. But I also want to emphasize that when cancer has just begun, there are no symptoms. So that's one of the reasons why people present late. Somebody will have a swelling in the breast and it's cancer, and they will have it for 3 years, and they think it will go. By the time they feel pain, they come and say the cancer is advanced. Okay. And that underlines the reason for frequent checkup. I'm using the word checkup because some cancers cannot be screened for, but frequent checkup. Thank you very much.
Thank you very much. Let's quickly take the next question from Jaman Natwera, who says, thanks to the Ministry of Health and Government of Uganda on efforts geared towards improving cancer care and palliative care access in Uganda. However, a significant number of cancer patients are still unable to access or continue with cancer care due to cost, financial limitations, say for buying cancer treatments such as chemotherapy, etc. There is also still inadequate human resource, oncologists, palliative care specialists to offer care to the ever-increasing number of cancer patients. What does Dr. Omoding and Dr. Walusansa say about this?
I'll go first.
Yes, Dr. Walusansa.
Yes, it is true that we have few specialists in the country. And I spoke about this, that we are trying to decentralized care, because the cost of coming for care at the UCI are not just transport and are not just related to the drugs, because the drugs are free. The drugs are free for the basic drugs are there. It is the highly specialized drugs that maybe come out of clinical trials, the newest babes on the street are the ones that are very expensive. But the traditional drugs that we use for cancer care are available at Cancer Institute for free. But there is a cost associated with transport and then feeding, which cannot be met by the institute. So I agree that it's costly. That's why we are trying to see that can we take the treatment to the community and make sure that the cost for transport are cut out, and that means that they can access treatment. And in so doing, in setting up these regional centers, we are thinking that the cost will be cut out drastically. And these regional centers will be also equipped with diagnostic services. It is not just cancer care is not delayed by only the treatment. Even the diagnosis, in the days that I started practicing, the sample used to come from Arua and take 2 weeks, take actually 6 months before the results get back for the patient to come. So by the time the patient came, they were stage 4, but they had presented to the center early. So having that timely diagnosis and timely referral and timely access to care is very important for us, and that's why the strategy we've taken is to decentralize care. We hope that after we have decentralized to regional, we can decentralize and cascade up to even district hospitals, because we cannot go to levels that are below that, because it is a specialized care, and most of the services we are giving come with side effects that would need somebody who is trained to look after them. So yes, that is what we are trying to do. I agree that there are few trained oncologists, and that I speak about what Abraham says, that in previously people trained, and after they are trained, because they are not being paid the exact amount of money which the people where they went to train from are receiving, they actually go out. Many of our people who are trained actually moved out. So we decided to train in the country. We are training from inside. We are training from here such that we can retain more. Definitely, we don't say we shall train all of them, but if they are trained on a government scholarship, definitely they will stay, and they are trained here, and hopefully they are not exposed to the exorbitant pay that the specialists out receive. Yes.
Thank you very much, Dr. Usasa. I think you've also responded to Manjit, who was saying, in addition to oncologists and PC specialists, what about training oncology nurses? So I'm going to come to each of us, and I'll start with you, Dr. Usasa. In less than a minute, what would you like us to take home from this conversation today? Just very quickly, we have 5 minutes, and there are 5 of you.
I think what I want us to take from this interaction is that cancer care is improving, and there is still room to improve, and the Cancer Institute is poised to go the extra mile to make sure that there is accessible care in a timely manner to patients by all the interventions that we've discussed. And I encourage us to live safely. I encourage us to screen. I encourage us not to wait till we feel the pain, that anything that we have should be reported, and insist on having it logically examined and explained away by a clinician.
Thank you very much.
Yes.
I'll come next to Ms. Rose Chuanuka, palliative care nurse specialist.
Thank you very much, Josephine. Mine, I would like to say that this palliative care knowledge, every healthcare worker needs this knowledge so that patients can be helped wherever they are, because patients are everywhere, and we can't run away from palliative care with this increasing cancer and non-communicable diseases. Thank you.
Thank you very much. I'm going to come to Dr. Agasha Doreen Birungi.
Thank you very much. My take home and my message to the viewers is that the palliative care is important, and we really need to take this policy forward. This is really an appeal to all stakeholders involved. It's important for service provision, for training, and for the support that we need to deliver this service. So it's really imperative that we move very fast to get our policy approved so that we can do better. Yeah.
Thank you very much. Dr. Chair, I'm going to skip you for now. You started this. I would like you to end it. So I will come to Dr. Omoding. What would you like us to take home from this conversation?
Thank you very much, Josephine. Really, my take-home, message for the viewers is prevention is better than cure, and we grapple a lot with patients who come with cancer, more so in very late stage disease. My word to the audience is, and the viewers is, prevent cancer. Learn the key things that you must do right in order not to get cancer. Go get vaccinated for the vaccinable cancers. Adhere to regular medical checkups and screening so that if you developed it and it's caught early, you will be curable. And on top of that, we are in the COVID era, and adhere to the SOPs. Make sure you wear your mask, you sanitize, you wash your hands, and you social distance. Thank you very much.
Thank you very much, Dr. Mading. You've set the stage for Dr. Chove to wrap up in less than a minute, Dr. Chove.
Yes, Dr. Mading has done part of my work, and thank you so much, Abraham, for this. First of all, thank you so much. This has been a very great interaction and a very good conversation. But of course, to pick it up from here is that the interaction of the disruptions that came with the COVID, not only in cancer care, but also other illnesses, but not only other illnesses, but also the general population, the economy, things that we had to bear to some extent, but we could avoid them if we really do what Abraham has said, SOPs. But more importantly, now that we have a remedy, that are the vaccines. We have several molecules that have come through. Initially, we were battling and we didn't have vaccines, but now they are coming through. There may be smaller operational challenges in the access, but those ones will get over them. And I know in the next few months, 2-3 months, we'll have enough vaccines which we should take up so that we get all these things out and then return back to our normal lives. Thank you very much,
Dr. Chove. I'd just like to say a big thank you to the panelists for their dedicated service and for discussing these very important issues today. We have heard about the efforts in fighting the pandemic. We've heard about the impact of the pandemic on the fight against cancer and the impact on palliative care. And we certainly hope that there will be useful lessons for the country to make progress on all three fronts. Thank you so much for staying with us. We now hand you over to the next session that's coming up. Thank you for staying with us.
I'm Joanny Takawalia, the Pikau Goodwill Ambassador. I'm here to inform you that Uganda Cancer Institute, together with the Palliative Care Association of Uganda, in partnership with the Ministry of Health, will host the 3rd Uganda Conference on Cancer and Palliative Care on 23rd and 24th September 2021. The theme of the conference is Cancer and Palliative Care in COVID-19 and Other Challenging Situations. This year's conference is a unique one and will be held virtually with some sessions broadcast live on UBC TV. We will have panel discussions, plenary sessions, and workshops, as well as presentations of abstract, where scientists will share latest research on cancer and palliative care. This conference will bring together at least 400 policymakers, researchers, health providers, patients, and the general public who will be watching online. I encourage you all to register for this important event. Registration for Ugandan delegates is 200,000 shillings.
For more information, call 0392 080 713 or 0414 540 410. Email conference@uci.or.uj or conference@pcau.org.uj.
My home, I smile when I think of you, Uganda. My home. My home, I dance when I look at you, Uganda. My home, oh my Uganda.
I know with you I'll